So we'll discuss about the bladder. We'll discuss about the urethra and the prostate here. Okay. So what is this in the right corner?
It's a walnut.
Yeah, it's a walnut. So why walnut here is the shape of the prostate and walnut is almost the same. The size also is the same. So in FMG they sometimes ask crazily the size, some numericals. Okay. So it is 18 to 20 grams. I have seen this question before, like before 2018, they have asked the size of the prostate. What is the normal size of prostate? It is 18 to 20 grams. Okay. So for that, this image. So this is the normal prostate here. This is the enlarged prostate here. What is this? What is the surgeon doing here?
Size would be, it would be weight, no? So 18 to 20 grams.
Yeah, it is the weight. Sorry, it is the weight on.
DRE, digital.
Yeah, it is the DRE, digital rectal examination or perectal examination. Okay, on perectal examination we can feel it. Okay, and then this is the cut section, and this is the sphincter here below, bladder neck here. Okay, everything is important. I'll tell you. So jonal anatomy. Apart from our normal anatomy, there is a jonal prostatic anatomy. Jonal prostatic anatomy was given by McNeil. Remember the surgery name or surgeon's name also. McNeil. MEC McNeil. NEAL Neil. McNeil's jonal. Who gave the prostatic jonal anatomy? McNeil. Okay. So he divided into 3 zones: central zone, transitional zone, peripheral zone. Transitional zone, BPH is more common. Peripheral zone, carcinoma is more common. This used to be the most favorite question of the examiners. Peripheral
Could you repeat that again, please?
Yeah, I'll repeat. So transitional zone, BPH is the most common thing to arise. Transitional zone, BPH. Okay. Peripheral zone, cancer prostate. Carcinoma prostate is the most common thing to come. Okay. Yes, no?
Yes, sir.
Yeah. So here comes an important term called, what is this?
Lower urinary tract symptoms.
Yeah, lower urinary tract symptoms. Lower urinary tract symptoms. Sorry. Okay. So can you name some lower urinary tract symptoms?
Dysuria. So obstructive
Dysuria,
symptoms could be
anuria.
there. For example, hesitancy could be there. Intermittency would be there. And poor flow of urine.
Yeah. Okay. Irritative symptoms. Irritative, what are the 3 irritative symptoms?
Frequency.
Yeah.
Nocturia.
Okay.
Urgency.
Yeah. Only 3. Frequency, urgency, and nocturia. These are the 3 irritative symptoms. Okay. Whenever in lower urinary tract, if the patient is having frequency, if the patient has urgency, if the patient has nocturia, we classify him under irritative symptoms group. Irritative symptoms. Obstructive symptoms are different. What you told in the before. Poor flow, intermittency, hesitancy, dribbling, incomplete emptying. These are all obstructive symptoms. So on perectal examination, on PR examination, if you find a tender boggy prostate, what is the diagnosis? If you find a firm rubbery mobile mucosa, what is the diagnosis? Or if you find a hard nodular fixed mucosa, what is the diagnosis? 3 things. These are 3 separate things. First, tender boggy prostate. Prostate is very tender. What do you suspect?
Prostatitis.
Prostatitis. Okay.
Acute bacterial prostatitis.
Prostatitis or prostatic abscess. Prostatitis or prostatic abscess. Okay. Either of these things will be there. Prostatitis or prostatic abscess. Okay. If the prostate is tender, if the prostate on PR examination, if it is firm, if it is rubbery, if the mucosa is mobile, then it is known as BPH. If the mucosa is hard, if the mucosa is nodular, if the mucosa is fixed, then what is that? Fixed mucosa.
Carcinoma.
Yes, carcinoma. BPH arises in which zone?
Transitional zone.
Transitional zone. Carcinoma arises from which zone?
Peripheral zone.
Peripheral zone. Others also are able to understand. So we are discussing on the digital rectal examination. If there is tender boggy prostate, it is a prostatic abscess or a prostatitis, chronic or acute prostatitis. If it is firm, this will be asked. Okay, so this same wording will be asked. Firm, rubbery, mobile mucosa. Firm, rubbery, mobile mucosa. Hard, nodular, fixed mucosa. So these two you have to understand. Same wording will be there for BPH and for CA prostate. So we'll discuss about the various investigations we have in our this thing. This is the uroflowmetry. There will be a graph where there will be flow and time. So we have a curve like this. So what happens in obstruction is, in urinary obstruction or anything like that, there will be, the curve will decrease. Normally the flow will be around 10 ml per second. If it decreases, then we know that the patient is having obstructive urinary symptoms. Okay. So this is about uroflowmetry. Just males will be standing and voiding, and females will be sitting on this couch on a specially designed chair, and they will be voiding on a machine. So we will record the flow and the time. We will get the flow rate. So here one small concept to discuss. Suppose this is the bladder, this is the urethra, this is the prostate. So what are the causes of poor flow? Uroflow shows poor flow. This is a normal uroflow. The patient has poor flow. So what are the causes for poor flow? Just think and tell. Nothing great in this, just logic only. Just think and tell me.
Obstruction.
One is obstruction. One is obstruction. Okay. Any other?
So can anatomical reasons be a reason? Can that be
Anatomical obstruction? You mean by prostate enlarges, so it is anatomical obstruction only, or a pathological obstruction, stone or something.
stones?
Whatever
Yes, sir.
it all comes under obstruction.
Okay, sir.
Yeah. Any other thing for poor flow? See, this is a pump mechanism.
So can backflow be a reason? Reflux.
Backflow for obstruction, for poor flow.
Yeah, I'm just guessing. Sorry.
No, backflow will not be a reason, because backflow will cause fever and all, because urine is going into the bladder. The urine which is coming into the bladder, which will go and reflex in high pressures, so it will cause pyelonephritis, but it will not cause poor flow.
Okay, sir.
See, for urine to void, we have two things. One is the bladder should contract normally. The pump, bladder is a pump, right? The bladder should contract normally, and the outlet should be free of any obstruction. We discussed about obstruction, but we are not discussing about this one, pump failure. One is bladder pump failure. Okay, bladder failure we call it as bladder pump failure. If the bladder's capacity to pump, got it? If the bladder's capacity to pump the urine outside is gone, then there will be poor flow, right?
Yes, sir. Got it.
Yeah, two things. Only the one is the bladder pump, the intrinsic bladder function is poor, or outlet obstruction is there. Either of these two are the culprits for poor flow of the patient. So in which conditions the bladder capacity will be decreased? Can anybody tell me? In our house
bladder.
Sorry?
Neurological defect.
Bladder.
Neuro, somebody say neuro?
Neurogenic bladder, sir.
Yeah, neurogenic bladder. Yeah. Neurogenic bladder is a broad term. So to be specific, in our homes, elderly people, what will be, they'll having diabetes. So what is that? Diabetic cystopathy. Okay, diabetic neuropathy and diabetic cystopathy. If they have this diabetes, there will be pump failure. So they will have poor function. One. And then any trauma, neurological trauma, any spinal cord injury or any trauma, neural trauma will cause poor function. Or any surgery, okay, lower abdominal surgery, any gynec surgery, colon surgery, anything, and the nerves are getting damaged, there also bladder pump failure will be there. Intrinsic bladder function will be decreased. So these are the two conditions where uroflow will be poor. Good? Yes, no?
Yes.
Okay. So how to differentiate between these two? How to differentiate between these two? Whether the patient's bladder function is poor or outlet obstruction is there. If you do these tests, uroflowmetry, you'll get only poor flow. But we don't, for this poor flow, there are two reasons. One is bladder, one is outlet. So how to differentiate? For that, this test is useful. This is CMG. What is CMG? Simple. This is not a complex thing. Just pay attention. One is poor flow. I am talking about an entity called poor urinary flow. Poor urinary flow. It may be due to two reasons. Bladder reason one, bladder is not pumping at all. So the flow is poor, one. Or outlet is obstructed due to anatomical reasons or pathological reasons, either stone or a prostate or a stricture or a meatus, something. Outlet is obstructed. So then also there will be poor flow. Clear? Clear till now, at least?
Yes, sir.
Yeah. So how to differentiate between these two? What is the reason for this? Then only you can treat right. If there is outlet obstruction, you just remove the prostate. If there is a meatus, if there is narrow meatus, you dilate the meatus. If you have a bladder functional abnormality, you give some medicines to improve the bladder function. So first you have to know how to differentiate between these two. That is by doing anybody? What is CMG?
Cystometogram.
Cystometrogram. Very good. It is nothing but it is to measure the pressures in the bladder. So suppose if there is high pressure and low flow, the bladder is pumping nicely, but there is low flow. What does it mean?
Outlet obstruction.
Very good. Outlet obstruction. Excellent. Suppose see, if there is low pressure and there is low flow, then what is the reason? Pressures are low in the bladder. Bladder pressures are low and flow also is low. Then what is the reason? First you told outlet obstruction. Then
Bladder failure.
bladder pump failure. Intrinsic bladder function is not, bladder only is not contracting. That is the pressures are low inside. Okay, got this point? Very important, and make sure you know that. Uroflow, if it is poor, two reasons. One is outlet obstruction, one is bladder function is poor. So to differentiate between these two, you need to do a pressure study known as cystometrogram. Cysto is bladder, metro is pressure, and gram is study. Study the bladder pressures. So here if you find if there is high pressure and low flow, that is one reason. High pressures are there, bladder is nice. Low flow, outlet is gone. So you have to do a surgery in this patient. Low pressure, bladder is not contracting properly. Low pressure and low flow is there. Low pressure is there, low flow is there. Then you have to go for give some medicines to improve the bladder function. Okay. And then we have another test called the PSA. What does this PSA mean?
Prostate specific antigen.
Prostate specific antigen. Okay, it is a tumor marker actually. It is a tumor marker. The normal value should be less than 4 nanogram per ml. Nanogram per dl. Okay, so this should be the normal. If it is increasing, then the chance of malignancy increases. Okay, so this is a tumor marker. This is for first investigation uroflow. Then you do a cystometrogram. Then you do a PSA, and this is post PVRU is nothing but it is post-voidal residual urine. Post-voidal residual urine. What does this mean? Suppose see the patient is having a bladder capacity of 500 cc say. So he is voiding, and after voiding only 10% should be there inside. That is only around 50 ml should be left behind. If anything more than 50 is there, then he is having high PVRU because he is having obstruction. High PVRU, post-voidal residual urine. Simple, right? Post-void. After you void, there is some urine, residual urine. That's it. Okay? Yes, no?
Yes,
Yes,
sir.
sir.
So suppose BPH is there, benign prostatic hyperplasia.
Post-viral residual. So post-viral residual urine is found in what conditions, sir?
It's found in
What are the conditions which we can see
obstruction, in
mostly?
urinary obstruction.
The
All these
post-viral
cases,
urine of about
all
6
urinary obstruction like BPH, stone, in stricture, there will be high post-void residual urine. Any obstruction, anatomical or pathological obstruction, there will be residual urine, residual urine.
Okay, sir.
Yeah. Then coming to BPH. If a patient has BPH, BPH is benign prostatic hyperplasia. In recent one examination, they asked about BEP. What is BEP? It is almost the same. It is benign enlargement of prostate. Don't confuse. Both are same. BPH and BEP are same. Benign prostatic hypertrophy, benign prostatic hyperplasia, benign enlargement of prostate. All are same. Okay. So you give medical management. Can anybody tell me a few drugs, pharmacology, which are used to decrease the size of the prostate and reduce the symptoms?
Tamsulosin,
Yeah.
Alpha blockers.
Finasteride.
Yeah.
prazosin,
Tamsulosin, not projosin. We give silodosin, tamsulosin, alfujosin,
Doxazosin.
These are all alpha blockers. Alpha blockers. Okay. And then we have finasteride and dutasteride. Dutasteride. What is this? This decreases size of the prostate. What is this? Class of drug? Dutasteride?
These are 5-alpha reductase inhibitors.
Yeah. Okay. So if medical management fails, you will start, every patient will start on medical management only, no surgery at front. First, if medical management, then if it fails, that means the symptoms are not improving. The patient is still having irritative symptoms, still having obstructive symptoms. Then we'll go for what option next? If surgery, then what is the next option if medical management fails anywhere?
surgery,
Yeah, surgery. We'll go for surgery. So here also surgery. In the past, there is open surgery. Nowadays, there is TURP, transurethral resection of prostate. Transurethral resection of prostate. Transurethral resection of prostate. So this is TURP. So how is this a invasive procedure or minimal invasive procedure?
Non-invasive.
It is an invasive, not a non-invasive procedure. It is an invasive procedure because we are going inside the patient. But it is invasive or minimal invasive? That is the question.
Minimal invasive.
Minimal invasive because we are not opening anywhere. Earlier days, open surgery means we have to open it. Nowadays, we are just putting a small scope inside. Okay, we are putting a scope inside the bladder and resecting the tumor outside. Okay, that is TURP. And future, nowadays, already started, and by the time you complete your post radiations, this will be the future, laser prostate. Okay, everybody will do laser prostate surgeries. Okay, so TURP here, see, this is a pictorial representation. We'll put the scope known as a resectoscope inside the bladder. We'll just put a scope inside the bladder and we will resect the tumor outside. This is transurethral resection of the prostate. Okay, this is just a pictorial representation. So what are the limits from where to where you have to resect? So you have to start resecting from here, from this to here. You have to resect the gland completely so that the patient will void normally. Okay, so what are the limits they'll ask you? One is this, what is this? What is this?
Bladder neck.
Yeah, what this is the bladder
Neck.
And here this is the, I told you what is this?
Sphincter.
This is a sphincter. Okay, so this is the sphincter and this is the landmark here, Veru. This is known as Veru. Veru Montanum, we call it as Veru. Okay, anatomy we read in the first year, we forget mostly, but this is the Veru. So the Veru is the landmark for sphincter. We should not cut beyond this because the sphincter goes, once the sphincter gets damaged, what will happen?
Crippling of urine.
If the sphincter gets damaged, what will happen? Urinary?
Loss of control.
That is what is not known as
Incontinence.
incontinence. Okay.
Incontinence.
Yes. So these are the limits of TURP. Bladder neck 1 and sphincter is the other. Veru is the other thing. So these are the limit. Okay. Then there is a complication. There is a complication called retrograde ejaculation. Retrograde ejaculation. What happens is, normally the semen will be released from this prostatic utricles and it will travel in only one direction. It will come outside through the meatus because the bladder neck is closed normally. But after TURP, the bladder neck is wide open. So there will be spillage of semen into the bladder. Okay, this is the most common complication, retrograde ejaculation. So if you do 100 TURPs, 95% will suffer with this complication. So you have to explain it before only. Retrograde ejaculation. So instead of semen coming outside through the external meatus, the semen will go inside the bladder because the bladder neck is weak. You have made it weak. Okay, clear this point? Yes, no?
Yes, sir.
Sir, but with such a complication, do people really do this surgery even now?
Yeah, see, because it is age after 60 years, most of the times, even to 60 to 80, BPH is common. Okay, so we explain properly and we can take it for surgery. Because obstructive symptoms will eventually land the patient into renal failure. Okay.
Okay, sir.
So that is a every patient will suffer with that. Almost every patient will suffer with that. Okay.
Okay, sir.
Yeah. And see here, has anybody underwent endoscopy among you for any other gastritis or something? Did you undergo endoscopy?
No.
Yes, no, others also?
No, sir.
Okay. So why I'm asking is, when you put an endoscope inside to look at the stomach, look at the esophagus, they put some media, like they insufflate air inside, so that the esophagus is a collapsed tube. If you put a tube, it won't go inside. So you have to push some air inside. So if you push air, that cavity will open. Then only you can visualize. In the same way, the urethra is a collapsed tube below. So if you want to see it from below, you have to give some fluid. You have to irrigate the bladder, irrigate the urethra. Then only you can see that. So what fluids we can give? There are two fluids, irrigation fluids. One is glycine, one is for normal saline. Both of them we can use, but most of the people will use glycine. Okay. So this is the most common irrigating fluid. Limits are important. Irrigating fluids are important. Glycine is the most common irrigating fluid which we use for bladder resection, TURP, transurethral resection of prostate. Okay, clear? Why we need a fluid? First of all, why we need a fluid?
Lubricant?
Sorry?
Like a lubricant?
No. Lubricant we put jelly, but see, this is a collapsed tube. Our urethra is a collapsed tube. So to make it open, you have to give some fluid. Then only it will open. Then you can pass your tube. Okay.
Okay, sir. So why is
whatever,
glycine? Sorry for interrupting you.
Yeah.
Why is glycine preferred and used more often compared to natural saline?
Yeah.
Normal saline. Sorry.
This will I have to discuss a little. You asked a good question. So just when we resect prostate, we use some current to resect the prostate. Okay. So are you following? We use some current.
Yes, sir.
Okay?
Yes, sir.
With the current, a loop will be charged, and with that loop, we will start resecting. So we have monopolar and bipolar. Two type of currents are there. You have seen in the OT maybe monopolar and bipolar. There are two type of currents. So when you use NS, what happens is the current will not. NS is a bad conductor. The current will not pass inside the bladder. So if you use glycine, it will pass adequately. Okay. So most of the patients prefer glycine if you use monopolar. If you can use bipolar, anything is same. But for monopolar, only glycine will work. Monopolar will not work. Okay.
Yeah, okay, sir.
Sir,
Yeah.
one more question, sir. So passing through the bladder or through the urethra, sir?
Passing through the
Urethra or the bladder, sir?
urethra.
Oh,
See,
yeah, okay.
this is the bladder.
So,
This is the urethra. Here lies the prostate. So your scope should go from here.
yeah.
You'll give fluid. You should go from here. Your scope will go here. Then you will pass some current and you will take it out. Both the tissues, both the lobes. Okay.
Yeah.
So then after surgery, it will look something like this.
So glycine helps to conduct electricity.
Yeah.
Passing
Glycine
through
helps to
the
conduct electricity. Monopolar. That is for monopolar only. Not about bipolar. Just don't go into that details. But glycine helps to transfer of electricity inside. But normal saline will hamper it. So we can't use NS for monopolar
NS.
surgeries.
Yeah.
If you use bipolar, which is very costly, then you can use NS. Most of them will not afford bipolar in our OT. Monopolar is available everywhere. That is the basic difference.
So this monopolar and bipolar, you're talking about the diatherms, right?
Yeah, diatherm same. Whatever the diatherm you use, same. Both are the same.
Okay, sir. Thank you, sir.
So in bipolar, the two prongs will be there, right? So no need, even if NS is a bad conductor of electricity, the current will pass between these two only. It is very short. But NS, it has to pass through, only one loop will be there in monopolar. Okay, so the NS should allow it. It is not allowing. So we can't use NS in monopolar. We have to use glycine only in monopolar. Okay?
Okay,
Yeah, okay,
sir.
So what is
So
this?
one quick question.
Yeah.
Regarding BPH, if the patient is presenting with hematuria on OPD, then what is the next way of surgical intervention? So the same urethoscopy, transurethral resection of prostate?
Yeah, same.
Because the patient is already in hematuria. He's bleeding.
Yeah, so first of all, we'll put the scope inside.
If the patient is bleeding from his...
Yeah. First of all, we'll put the scope inside. There will be clots inside. We'll call clot evacuation. We'll remove the clots inside. Because of the clots only, it is bleeding. So we'll remove the clots. We'll identify the bleeding point. We will fulgurate it. First of all, we will fulgurate the bleeding point. Then even in the same sitting or after the patient stabilizes, if anemia is there, you can give some blood transfusions, and once he stabilizes, you can do the surgery.
Okay, sir.
Okay. So what is this? Have you seen this?
Foley's catheter.
Yeah, Foley's catheter. What is
Yes,
the
sir.
difference between these two? Difference.
First one is two.
The number of openings.
The first one is two-way catheter. This is three-way catheter. Two-way, three-way. It has two ways here. It has three ways here. 1, 2, 3. So this is for urine. The urine comes like this. What is this for?
Injecting sterile water.
Yeah, injecting the sterile water to make the balloon open. So in three-way, see, urine comes from here outside. One. There is a same to inflate the balloon. This is to inflate the balloon. And the other one also is there. What is this for? Just think.
Is to inject the dye.
To inject the dye? No. Okay, that's okay. But to give some bladder wash. Okay. So we'll give some bladder wash inside. Suppose that somebody has asked, there is bleeding inside. So we'll put this catheter inside. We'll give a bladder wash. Saline goes here. Saline comes from here outside. So that the bladder is washed thoroughly and the urine will be clear again. So this is a three-way catheter. We call it as three-way catheter. Both these are used for prostate surgery. Just remember, three-way catheters are used to give bladder washes and give contrast also, as you told, but mainly for bladder washes. Okay. Complications. There will be hemorrhage. There will be pain. Sorry. There will be hemorrhage. There will be pain. And what is the most common complication?
Retrograde ejaculation.
Retrograde ejaculation. Okay. So now we'll move on to second concept in prostate. Prostate cancer.
So just a minute. Can you please show the previous slide?
This one? This one or previous one?
Yes, sir. Got it. This one, sir. Sorry, I
Hemorrhage.
was writing. Yeah.
Hemorrhage, pain, and retrograde ejaculation. And also incontinence. Incontinence also may be seen. Incontinence, once you, why incontinence?
Because of the bladder.
Sphincter.
Yeah, if you damage the sphincters. Okay. So, prostate cancer. What are the DRE findings of prostate cancer? How this will look, DRE?
It will be firm
Firm.
on palpation.
Yeah. Nodular, non-nodular.
Nodular.
Nodular.
Sir, I'm guessing.
Mucosa, is it fixed or is it mobile?
It's fixed mucosa,
Yes.
right?
Right. So, the risk factors are, they are mostly genetic risk factors are there, genetic factors. Okay. And the usual routine, our smoking, alcohol, everything is a risk factor, but mostly genetic factors. And if suppose a patient has prostate cancer, there is high chance that his son will have prostate cancer. So you have to put them on screening. So what is the tool for screening? Is screening done in normal population or diseased population? Normal or diseased population? First tell me this.
Normal, right? Screening
Right,
is done on
normal
normal.
population. So whenever the patient is normal, then only you have to do it screening. So for this you have to do DRE, digital rectal examination, and a PSA. It has to be done annually. Okay, screening should be done annually, and the modalities which you use are DRE and PSA. Okay. So the investigation here. So this is the prostate bladder, this is the urethra, this is the prostate here. The patient is having prostate. You suspect prostate cancer. You did a PRE, DRE, all the findings what you told were there. Okay, everything is there. It is hard, it is nodular, it is fixed. Then what you do? You suspect it is prostate cancer. PSA is 100. Then what you will do?
Biopsy to confirm.
Surgery.
Directly?
Biopsy to confirm.
Yeah, you should do the biopsy, right? It's not like every time, it is not like kidney. Kidney, there is no need of biopsy, I told you. There is no need of FMGE, there is no need of biopsy. Only for 3 conditions we will have, they like MLA, metastasis, lymphoma, and abscess only will do that. But here, in case of prostate, you need a tissue diagnosis. You need a biopsy. Okay. So how to get a biopsy from prostate? Prostate is somewhere below. It is in the. So how to get it done? So what is he is doing here? Identify the procedure.
Rectoscopy.
Endoscopy. Okay. It's not endoscopy. It is putting a scope in the rectum. This is
rectal biopsy.
rectal, and it is there. The surgeon is putting an ultrasound also. Ultrasound to guide where to take the biopsy. We'll put an ultrasound in the rectum so that we know where exactly the malignancy is there, and we'll take a biopsy. So remember, don't forget. See this image. So rectal ultrasound biopsy. Truss biopsy we call it. Truss biopsy. Transrectal ultrasound biopsy. Clear? So this is the investigation of choice. Transrectal ultrasound biopsy. So what is Corad's score? Corad's, in which disease uses?
COVID,
which disease?
right?
COVID, yeah. In the same way, before Corad's, actually it started with Birad's score. Birad's is used for
breast cancer. Breast cancer.
breast cancer. Birad's is used for breast cancer. In the same way, Birad's score is used for prostate cancer. Birad's score. Okay, it is just to know that what stage it is, early, mid, or late. This is truss biopsy. And remember only this term. No need to go into this table and all. Just remember, once you do a biopsy, you will get a score. That score is known as Gleason's score. Sir Donald Gleason was a pathologist, so he gave a score under his name. It is known as Gleason. What is the surgeon who gave journal anatomy of prostate?
McNeil.
McNeil. Journal anatomy of prostate, McNeil. Here it is Gleason score. Gleason score is used in which pathology, which cancer? Testicular cancer, prostate cancer, kidney cancer, like that the question will be there. So remember, Gleason score is
Prostate
used for
cancer.
prostate cancer. So management. Suppose you stage the disease, you did a biopsy. So 3 findings. One is cancer is located only here, prostate, inside prostate. 1. Cancer has spread outside. Cancer has spread somewhere else. A, B, C. What is the treatment options? A for A. What is treatment of B for what is C? Suppose it is localized. If it is localized here only. So what is the treatment?
Radical prostatectomy.
Radical
Prostatectomy.
prostatectomy. No need. No, you can't do a TURP because why you can't do a TURP? You can do a TURP, right? Prostate also you are removing the what is that in BPH also you are removing the prostate, right? Transurethral resection of prostate, you are resecting it. Then why not in cancer you can do that?
Because metastatic.
Because
Metastatic.
metastatic, no. Here the importance of that zones will come. Zones. Where does this cancer arise from?
Peripheral.
Peripheral zone. So whatever you're resecting in between. You are not touching the periphery. Okay, suppose this is a rim. Suppose this is the prostate. Suppose this is the prostate. In between you resect. You can't touch the periphery. So TURP is not of any use in prostate cancer. Remember this point for life. Okay. Yes. No.
Okay.
So it's only because of the zone that TURP isn't done for prostate cancer removal,
Not
right?
only because of that. This is the one reason. And the second thing, cancer you have to go extensively. You have to do a radical resection. Okay. So hello.
Yes, sir.
Hello, yes, sir.
So for in cancer, you have to do a radical resection. Okay. So you have to take completely. You have to take it off from here to here. You will take it off, and you have to suture the bladder to the urethra again. You have to do a vesicourethral anastomosis again. Whereas in TURP, you are not doing it. You are just removing the prostate, some part of the prostate, and the periphery is left. Okay. Suppose if it is locally advanced, it has come here B. Then can you do prostatectomy? No, it has spread. So you give radiotherapy, RT. You give radiotherapy, RT. If it is metastatic, for metastatic prostate cancer, what is the treatment of choice?
Chemotherapy.
Chemotherapy. What is that for metastatic?
Chemotherapy. It'd be bilateral orchidectomy there and adjunctive chemotherapy along with it.
Yeah, somebody was answering bilateral orchidectomy. Okay, so we wonder for prostate cancer. I am talking about prostate cancer. So all of a sudden, why orchidectomy? Can anybody tell me why orchidectomy?
Because it is metastasis to adjacent structure.
Sorry.
Metastasis to adjacent structures.
Yeah, it has metastasized. Then why are you doing an orchidectomy? Completely different. You are talking about prostate cancer. Prostate cancer has metastasized. So you are doing a testis removal. Orchidectomy is testicular removal, right? Why are you removing testis in a case of prostate? That's what.
Is it because it's very aggressive?
Okay.
Adjacent structure.
No.
Tumor may invade testis.
No. See, this prostate cancer, it all depends upon one hormone, testosterone. Okay. This androgens. Because of these hormones only, the tumor will grow. So if we knock out that source of hormones, there is less chance that the tumor will not grow further. So where is the source for testosterone in males? In testis. So we will do a bilateral orchidectomy. Remember this. In metastatic prostate cancer, you have to bring down the steroids, bring down the testosterone level, androgen level. So you operate via a orchidectomy. Clear now?
Yes, sir.
Yes, sir.
Yeah. So orchidectomy and cancer prostate. These are the other indications, just for completion's sake. Cancer of testis, anyway you'll remove. Torsion of testis you will remove. Certain cases of prostate cancer. Which certain cases? It is metastatic cases of prostate cancer you remove, and male to female surgery you remove. Okay. So, sorry. Yeah.
You can continue, sir.
Yeah, some background noise. Okay. Then we'll discuss about the urinary bladder. So here bladder trauma, bladder ulcer, bladder cancer. Three things we'll discuss. This is the bladder. This is the peritoneum. This is the peritoneum. This is the bladder. This is the peritoneum. So this is all extra peritoneum. Okay. So there are two types of injury to the bladder. One is extra peritoneal, and the other is intraperitoneal. Extraperitoneal and intraperitoneal. Two types of injuries. If the patient is on full bladder, if there is injury to the dome of the bladder, here, if there is some injury, then where will the urine go? Think logically and tell me. Where will the urine go?
In
To the
peritoneum. Into
Into the
peritoneum.
peritoneum.
yeah.
So he will develop peritonitis. Okay. Clear?
Yes, sir.
Yes, sir.
Yeah. Intraperitoneal injury. If the patient is suffering from intraperitoneal bladder injury, there is the dome of the bladder gets ruptured. The urine will go into the peritoneum. He will develop peritonitis, and it is a dangerous condition. Whereas extraperitoneal, if there is only injury outside, if there is injury extraperitoneally, the urine will extravasate into the extravesical space, extraperitoneal space. It is not a dangerous condition. Okay. Just we can put a police inside, drain the bladder nicely for 2 weeks, then the injuries will heal on itself. So which is dangerous out of these two? Intraperitoneal or extraperitoneal?
Intraperitoneal.
Okay. So see here, bladder rupture associated with pelvic fracture. Extraperitoneal. Pelvis is lies here. So any pelvic injury, there will be extraperitoneal injury to the bladder. Urethral injury associated with pelvic fracture. Urethral injury is posterior urethral injury. I'll discuss it in next coming slides. What is posterior urethra? We'll discuss. These are all the other. We'll complete it. So see here, this is an extraperitoneal rupture. This is the peritoneum here. This is the peritoneum and the bowel loops here. So here it is extraperitoneal injury. This is the intraperitoneal injury. The fluid has entered into the peritoneum. How to diagnose extraperitoneal and intraperitoneal bladder rupture? Extraperitoneal, it is most common. 80% of the injuries are extraperitoneal. It is due to pelvic fracture. There is some urethral injury also. Urethral injury. There will be pelvic hematoma because the pelvis fracture is there. This is the pelvis. The pelvic has fractured. Extraperitoneal injury is there. So there will be a pelvic hematoma here. The patient will have inability to pass urine, and there will be blood at the tip of the meatus because urethra also is damaged. The patient will have inability to pass urine and blood at the tip of the meatus. Okay. So these are the findings of extraperitoneal injury. Coming to intraperitoneal, it is trauma to the lower abdomen. Trauma to the lower. It is not anything related to pelvic fracture. It is trauma to the lower abdomen. It occurs in blunt or penetrating trauma. Most common in full bladder. The patient will come with pain and peritonitis. Okay, the patient will have pain and peritonitis. Intraperitoneal.
So can you please show the two images?
These two?
No, before that, the 26th and 27th slide. Yeah, this one.
So this is an extraperitoneal injury.
Okay, so the next one, sir.
This is an intraperitoneal. It is on the dome of the
Okay, sir.
bladder. Okay.
Okay, sir. Got it. Thank you.
So very important. This 6 points are very important. Here also, this is also very important. So investigation of choice is give some contrast in the bladder and take a CT. Investigation of choice is CT urogram or CT cystogram. Okay, CT urogram or CT cystogram. So now you have to tell me what is the treatment options for extraperitoneal injury. What you will do for intraperitoneal? What you will do? Intraperitoneal. First, tell me peritonitis is there. What you will do?
Laparotomy.
Laparotomy,
Very good.
peritoneal lavage
And
would be
discharge.
there,
Catheterization.
Yeah,
and
bladder repair.
repair the
Laparotomy and
defect.
bladder
Yeah.
repair. Okay. For extraperitoneal,
Catheterization.
just catheterization. For extraperitoneal, just put a catheter inside the bladder. It will heal on itself. Extraperitoneal. Okay. Now see these images. They may be asked in image-based questions. See here. Two things: teardrop deformity and flame-shaped hemorrhage. Flame-shaped hemorrhage.
Sir, can you point out the treatment, please?
Yeah. Treatment for intraperitoneal. It has peritonitis. So open the abdomen. Do a laparotomy. Midline laparotomy. Give a peritoneal lavage. Wash the peritoneum nicely and suture the bladder repair. Suture the bladder injury. That is for intraperitoneal. For extraperitoneal, you have to just put the catheter inside. Catheterization. That's all. Okay.
Thank you, sir.
So see here. See these images. See the bladder here. And here there is a hemorrhage. Flame-shaped hemorrhage. This is known as flame-shaped hemorrhage. Teardrop deformity. Bladder is in teardrop deformity and flame-shaped hemorrhage. Both are classically seen in extraperitoneal rupture. So in the question, if it is there as flame-shaped hemorrhage or teardrop deformity, go for extraperitoneal. There is always pelvic fracture here, 80%. Pelvic fracture will be there and urethra injury will be there in extraperitoneal. So what is this? Extraperitoneal, intraperitoneal.
This is intraperitoneal.
Anybody others want to answer? You can see
Extraperitoneal.
It's
What are
dome
these?
shaped, right? So
Yeah, it is extraperitoneal only. It is not going inside the bladder. What? But an indirect indicator is there here. What is this?
Nailing done.
Yeah, nailing has been done. So it has some nailing or some orthopedic procedure has
fracture.
been done. So what is this? There is a
Pelvic fracture.
pelvic
Pelvic
fracture is there.
fracture.
Yes. Indirectly, you have to deduce it like this. This question was asked in AIMS. Okay. So both of them are looking similar, but only on this finding we have to identify. The pelvic fracture is there, so they have put the nails. So it's mostly they have asked in such level. Okay. So here, see, this is an intraperitoneal classic. The bladder, the contrast is going inside the peritoneum. This is an intraperitoneal. You can see the contrast, right? This is all contrast going inside. Yes, no?
Yes, sir.
Okay. So now a small point about urethra anatomy also. What is the length of female urethra?
4 centimeters.
Male
4
urethra?
centimeters.
20
18 to 20
centimeters.
centimeters.
Okay. So male urethra has in 4 parts. What are the 4 parts?
Prostatic part.
Prostate,
Prostatic.
membrane,
Vulva.
vulva,
What is this? This is
Vulva.
sphincter. Between the
Vulva.
sphincter there is the membranous part. This is the
Spongy part.
bulbar part, and this is the penile part. PMBP. Okay. Simply this image. Prostatic, membranous, bulbar, penile. So the bulbar and penile are known as anterior. Prostatic, membranous are known as posterior. Prostate, membranous are posterior. Bulbar, penile are anterior. Okay. So urethral injury. So there will be, what are the classical findings? There will be blood at the meatus. Blood at the tip of the meatus. The patient will be unable to urinate. The patient will have a palpable bladder. Because he is not able to urinate, the patient will have a palpable bladder. There will be a pelvic hematoma collection here. High flying prostate. On doing PR, because of hematoma, the prostate is displaced somewhere else. High flying prostate, it is known as So these are all indicators for urethral injury. Okay, blooded the meatus, inability to urinate, palpable bladder. These are the three classical things. Bladder is full, but because the urethra is injured, he is not able to pass urine. So what is this? What is this? Manhole.
Fracture.
Or manhole or a straddle injury. It is known as a straddle injury. Yeah. See here on stepping on that manhole, it has hit his perineum. It has hit his perineum. So this is a manhole injury or a straddle injury. So see here, what is this? On the perineum it has hit. So what is it looking like? This is a hematoma. What is it looking like?
Figure of 8.
Figure of 8 or some insect, some bird. What do you call it? A bird or something?
Butterfly?
Yeah, butterfly hematoma. It's a butterfly perineal hematoma, straddle injury. Okay. Here the patient is having blood at the meatus. See, there is blood at the meatus. These are all pictures of urethral injury, blood at the meatus. So, urethral injury, either it can be anterior or posterior. What are the anterior urethra 2 parts? What are the posterior urethra 2 parts?
Anterior, bulbar, penile.
Bulbar, penile.
Prostate and membranous is posterior.
Prostate and membranous. See, posterior urethra, there will be inability to void. There will be blood at the meatus. There will be pelvic or suprapubic tenderness, penile, scrotal, perineal hematoma. Everything is damaged, and there will be high riding prostate. Because of pelvic hematoma, the prostate has gone up. High riding prostate. Okay. Whereas in anterior urethra, the more common than posterior. The anterior more common than posterior because of direct trauma to the perineum, straddle injury. Usually, no pelvic injury here. The pelvic injury will be there in posterior urethra. The patient will be unable to micturate. There will be perineal, scrotal, perineal, confusion, hematoma, fluid collection. Before we go into this question, just answer me. Pelvic fracture associated with which type of bladder injury, which type of urethral injury? Pelvic fracture associated with which type of bladder injury?
Extraperitoneal.
Very good. Which type of urethral injury?
Posterior.
Very good. Excellent. So see this question. Take 5 minutes to read this question and just answer me. I'll be back in 2 minutes. Just I'll charge my laptop and come. Just I'll be back. Yeah. What is the answer?
A. Bulbar urethra.
Bulbar urethra. Any other answers? Same. Everybody wants to go with bulbar. So why do you tell bulbar? Yeah, it's correct. Why do you tell it is bulbar?
Sir, by rule out, sir.
Because it's straddle injury.
Yeah, obvious. Manhole injury is there, straddle injury is there. So perineal injury to the anterior urethra. Anterior urethra, here only one part is given is bulbar. Prostatic and membranous both are posterior urethra. And bladder, no doubt, it is not the option. So go over bulbar urethra. Okay. Clear?
Yes, sir.
Yeah, simple. A single pointer will be there, which you have to pick. Okay. Manhole is the pointer here. So this type of question was asked in NEET. So just I wanted you to see this. What is the investigation performed?
So I can't view the image, so something
Okay.
is blocking it.
Now?
Yeah.
Okay. So basically it is a contrast image. Okay. There is a narrowing here. You can see circle here. Two circles are there. One green and one inside. Yeah.
Yes, sir.
So this is a stricture. Some stricture.
BPH maybe.
No, this is a stricture, not BPH. This is a stricture.
Oh.
It is a urethral stricture and it is a bulbar urethral stricture. So he is giving contrast from below into the bladder. So it is a
MCU.
retrograde
MCU with
ureterogram.
bulbar urethra.
Retrograde ureterogram with bulbar stricture.
Okay.
Actually, in the question, there is difference. See here, from here also there is a tube. Don't worry about this, but just for our sake, just if they give contrast from below, it is known as an RGO, retrograde ureterogram. We are filling the retrograde. Antigrade is coming up from above, kidney, ureter, bladder, urethra. That is antigrade. You are giving it from below. Retrograde ureterogram. You are studying the urethra. Retrograde ureterogram. Okay. Clear?
Yes, sir.
And he is having a stricture also. Okay. MCU I already told you. And then bladder ulcer. First of all, bladder trauma is over. Then bladder ulcer. Only 3 points. We'll go quick. It is known as interstitial cystitis. Interstitial cystitis. Cystitis is infection. Interstitial is in the interstitial spaces. It is also known as Hanner's ulcer. Hanner's ulcer. See the image classically. You can see the image, right? So it is seen in women. Bladder ulcer.
Sorry, the smaller box is hiding the image now.
Smaller.
Yeah, that one. That.
Now it's okay.
No, it's still. Yeah. Now it's okay, sir.
Okay. So actually we can't make it out with this image, but just for complete bladder ulcer, it is also known as interstitial cystitis. There will be an ulcer inside that is known as Hanner's ulcer. It is commonly seen in women. Okay. And then bladder cancer. Bladder cancer. There are 3 types of bladder cancer. What is the epithelium of the bladder? Known as epithelium of the bladder.
Transitional epithelium.
Transitional epithelium. Okay, so transitional cell cancer. It is 90% of transitional cancer, 5% squamous and 5% adeno. So what are the risk factors?
Smoking.
Excellent. Any other?
Bladder stones.
Okay. For TCC, it is smoking. Till now, I have not seen a patient of bladder cancer without a history of smoking. Okay. So that is a common thing, smoking. And dye industries, dye, people who work in rubber industries, petroleum industries, alkaline dye industries, their dye is common, smoking and dye industries. Carcinogens. Squamous cell carcinoma, stones. Adenocarcinoma in patent urachus. What is this urachus? Urachus, have you heard about it? Heard and forgot? Not heard.
Heard and forgot, sir.
Yeah. Urachus is nothing but it is a connection between the umbilicus and the bladder. Primitive connection which will disappear after life. But in some people it is patent. Urachus is patent. In those people there will be adenocarcinoma. So just know the terms here. What is the symptom? What is the symptom? Hematuria, gross painless hematuria. That is the symptom of bladder cancer. Suppose, see, the question will be like this: a 70-year-old male presents with a male smoker since 40 years, presents with gross painless hematuria. What is your diagnosis? First diagnosis will be
Bladder carcinoma.
bladder cancer. Okay, so that is the importance of single term, but it will differentiate entirely. Gross painless hematuria, remember. Okay, yes, no?
Yes, sir.
Okay, sir.
Then there is a tumor here. There is a tumor here. So how to resect this tumor? What are the ways you can resect this tumor?
Can you radically perform the resection?
Yeah, radical cystectomy is an option. Okay, then any other? How we did TURP?
Can you do that for metastasis?
No, how you did TURP? I'm asking. TURP from which approach?
Transrectal.
Trans?
Rectal.
No. TURP.
No.
I'm not asking biopsy. I'm asking TURP.
Sorry.
How you did?
Receptoscope.
Yeah, receptoscope through transurethra. So in the same way, bladder also can be approached transurethral. So transurethral resection of bladder tumor. You can do it from below only. Transurethral resection of bladder tumor. Okay? Clear?
Yes, sir.
Yeah. And then how to stage it by using a cross-sectional imaging, CT or MRI. You can stage it. Management. I'll just tell you management part. This is the bladder. This is the tumor. What muscle is there here in the bladder? There is a muscle in the bladder, right?
Is it detrusor?
Yeah, detrusor muscle is there. Detrusor. So there are two types of bladder cancers. One is which will lie here only. It is superficial bladder cancer, SBC, superficial bladder cancer. And one is it will go into the muscle invasive bladder cancer. These are two things. If it is superficial bladder cancer, when you do TURBT, it is enough. If it is muscle invasive bladder cancer, you have to do radical surgery. Only two things, remember. Okay, muscle invasive, you do radical surgery. If it is superficial, just TURBT is alone. Alone is enough. Okay, clear? Clear, not clear?
It's radical what?
Radical cystectomy. Remove whole of the bladder.
Okay.
Okay. So after that, you give intravesical treatment. Intravesical, you can just give intravesical BCG or mitomycin C. See here, this BCG is the one which you use for which disease? BCG.
Tuberculosis.
Sorry?
TB, sir.
Yeah, TB. The same for TB which we use, the same we can use it here also. Okay, but we give intravesically. Okay. Suppose you do a cystectomy. This is the kidney. This is the ureter. This is the urethra. The patient has a bladder cancer. You have removed this part now. This part is gone. You did a radical cystectomy, RC, radical cystectomy. So now the patient is like this. He is having the kidneys. He is having the prostate. He is having the urethra. No bladder. So what will happen if you leave it like that?
Continuous urination.
Continuous?
There is no drainage of urine.
Sorry?
Continuous
There is no drainage of urine.
Yeah, there will be urine leakage into the abdomen because you have removed the connection and you have left it. You have not done any reconstruction here. So what you should do now? You have to reconstruct. You have to do something, right? So what all you can do? See here. You can put a small piece of bowl here, ileal conduit, and take it outside. The patient will have a pouch here. Urine will be collecting there. He will be emptying it. This is one. This is urostomy, known as urostomy. Urostomy. Or you can put a colon here, or directly the tubes. Both the tubes you can put it here. Okay, both the tubes you can directly put it here. Ureterostomy, this is known as either eye level conduit, colon conduit, ureterostomy, and finally it will look like this. So you have to do some reconstruction compulsory. Okay. Yes, no?
Yes, sir.
Yeah. So identify this procedure. Can anybody tell me? Identify this
So
procedure.
keeping an ileal conduit, will it fulfill the function of a bladder?
No. See, bladder has continence function also. We will know whenever we want to void only we'll void because bladder has its continence function. But ureter, this peeping ileum, it will just act as a temporary reservoir. That's all. Whenever it is full, it will just leak outside. So we'll keep a bag and we'll collect it.
Okay, sir.
Clear?
Yeah, fine, sir.
So
Is it ileal conduit, sir?
sorry.
Is it ileal conduit, this one?
No, not ileal conduit. This is different.
Sigmoid?
No. Identify. So it is difficult. Okay. So see, this is the kidney. This is the ureter. This is the bladder. Suppose any iatrogenically, if some part of ureter gets damaged, this part of ureter got damaged. Okay, only this ureter is left, bladder is left. So we have to bridge the gap. We have to bridge this gap. Okay, how to bridge? So they have made a small opening in the bladder. Like this, they will opening. See my image here. They are making a. This is the bladder. They have made a small opening in the bladder, and they'll tubularize it. They'll just tubularize it to form the ureter, and they'll close the bladder. See here, this is the defect here in the first image. Second image, they have taken a small piece of bladder and they have tubularized it. And third, they have reconstructed it. This is known as Boari flap. B-O-A-R-I, Boari flap surgery. So this can be asked as an image-based question, high possibility. So just easy. There is a ureteric defect. To close the ureteric defect, bladder flap is raised. There is a ureteric defect. To close the ureteric defect, the bladder flap is raised. That's all. Clear?
Yes, sir.
Yeah. This is a